Good evening, everyone, and welcome. My name is Samira, and I am a patient living with seronegative neuromyelitis optica spectrum disorder. I'm also the founder and executive director of the Samira Foundation, and it is my pleasure to host tonight's webinar, Navigating NMOSD in Canada, featuring Dr. Dalia Rotstein, Associate Professor of Medicine at the University of Toronto. A couple of things before we get started. So first, we actually have our first Canadian Patient Day this weekend in Toronto on Saturday, and I can't even believe it, but this is the first time ever that we've had over 200 registrations. So I'm very excited to meet all of you in person on Saturday. If you haven't yet registered, you can show up the day of, and we'll make it work. The second thing I wanted to say is that Canada holds a very special place in my heart. I live in Boston. I am American, but I love Canada. I love Tim Hortons. I love Timbits. Um, and actually, TSF Canada was the first international legal entity that we established, and this was about 5 or 6 years ago. So I have thoroughly enjoyed getting to know the patients, the caregivers, the doctors, the therapy partners in Canada, and I'm really looking forward to this weekend. A very big thank you to Alexion and to Amgen for supporting tonight's webinar. Patient education is so important. I always say that knowledge is power, and the smarter that you can get on your disease, the better you can advocate for yourself. So very grateful to our sponsors. Tonight's webinar is being recorded and it will be available on TSF's website and YouTube channel next week. So in case you have to scoot out early, or if you're watching this after the fact, this webinar will live on the internet for as long as the internet exists. Lastly, after Dr. Rotstein's presentation, there will be dedicated time for Q&A. So please enter your questions into the chat or Q&A functions. We'll get to as many as we can. And just a friendly reminder that we need to keep the questions high level and kind of broadly speaking. Dr. Rotstein cannot answer questions about your individual care or treatment plan. So just keep that in mind when you are asking your questions. So with that being said, it is my pleasure to turn it over to Dr. Rotstein.
Thanks so much, Sumaira, and thank you all for coming out tonight to listen to this series about NMOSD. So I'm delighted to be here. My name is Dr. Dalia Rotstein. I work at the University of Toronto, and I'm a neurologist at St. Michael's Hospital. And this is really a unique opportunity to give you more information about the disease. And I'm really happy that we're devoting half of the time to a question and answer period. So please don't be shy and speak up because we're eager to answer your questions. So this is just an outline for the first half of this evening. So we're going to talk about NMOSD in Canada. I'll talk about some features that are unique to our NMOSD population here. We'll answer the question, what is NMOSD? We'll talk about what the first NMOSD attack can look like. Then we'll turn to addressing how NMOSD is diagnosed. We'll then speak about how to recognize an attack and what kinds of treatments you could expect if you develop an attack. We'll speak as well about choosing a long-term therapy. And then lastly, we'll talk about resources and finding support. So I'm sure a lot of you are familiar with this map of Canada. Of course, we have a very, diverse country covering a lot of land. And I know that there are very distinctive characteristics depending on which province you live in. And medicine here in Canada is administered on the provincial level. So my experience is from my work in Toronto, where I work at the Barlow MS Clinic at St. Michael's Hospital. So I'm very used to some of the rules, governing care of NMOSD in Ontario, and I apologize in advance if, the rules may be a little bit different from those you have in other provinces. But I think some of the general principles apply, and I'm interested to hear about your experiences too in your own home province. And I also wanted to give a little shout out to the Blue Jays. Of course, it was a very exciting, although somewhat disappointing past week, but we have a lot of pride in the Jays, including at my home away from home. So this photo is from the MS clinic, which really is my home away from home. I spend a lot of my waking hours there. So let's talk a bit about NMOSD in Canada. And as Sumaira said, we actually have our first patient day in Toronto on Saturday, and I hope to see many of you there. We really appreciate the Sumaira Foundation support, and it's really going to be a very special event where you'll have a chance to meet other patients living with this disease, and also people living with other rare neurologic conditions. And I think it's really important to have that kind of support when you're living with a rare disease. Prevalence of NMOSD is only around 1 in 100,000 in Canada. So, it is quite rare, but it's similar to rates of NMOSD elsewhere in the world. So the incidence of NMOSD, which refers to the number of new cases of the disease each year, is around 1 in a million people. We also know that certain groups are disproportionately affected by NMOSD. NMOSD is much more common in women than in men. So about 80 to 90% of those affected are women. And it is also more common in individuals of Black and East Asian background here in Canada compared to the rest of the population. The attacks in NMOSD can be disabling, but many people with NMOSD are doing much better than they were 10 years ago. And this is thanks to many tremendous advances that have occurred in the treatments available. And I think moving forward, we can expect that people are going to have even better outcomes. So our goal really for people with NMOSD is to stop the disease after the first attack and to prevent any cumulative disability from arising over time. So let's turn to the question of what is NMOSD. As many of you know, it stands for neuromyelitis optica spectrum disorder. It is an autoimmune disease of the central nervous system. So we all have immune systems that usually fight off infections, but sometimes the immune system can become overactive or go awry, and it can attack the body itself instead of attacking, infections or intruders. So in the case of NMOSD, it's attacking the central nervous system, meaning the brain or the spinal cord or optic nerve, or sometimes two of the three or even all three. So this figure here just illustrates in a very basic way, the different locations where we can see NMOSD attacks. So one is in the optic nerve, and the optic nerve is the cable that essentially provides visual information from the eye to the brain. Then we can have NMOSD affecting various areas of the brain. And then NMOSD can affect the spinal cord, which runs from the base of the brain all the way down to the sacral area. Most people with NMOSD will have multiple attacks if not treated. So with an attack, an individual develops neurologic disability that increases over days to weeks, and then it stabilizes. Most people improve, but often people don't go completely back to their baseline and they're left with some residual disability. So for that reason, we try to prevent attacks as much as possible. And unfortunately, NMOSD is a chronic or lifelong disease. So once you develop the disease, unfortunately, you're stuck with it. But we are lucky that we have many treatments today that can help to change the course of the disease over time. And I have here, in all caps, that NMOSD is not multiple sclerosis. And some of you may have had the experience of getting misdiagnosed with multiple sclerosis originally and only later being told that you actually have NMOSD. And part of the reason for that is because the attack types that we see in NMOSD can overlap with the attacks we see in multiple sclerosis. And the other reason is that multiple sclerosis is a much more common disease, especially here in Canada. So multiple sclerosis affects about 1 in 400 people in Canada and as much as 1 in 250 women in Canada. But it's very important for physicians to be educated about NMOSD so that they can recognize this disease early on and send the diagnostic blood test, which we'll talk about in a minute. Why does NMOSD occur? So as we said, it's a disease of the immune system. I know this figure is a bit complicated, but we basically have, these different immune cells out in the peripheral blood. And one of them is the B cell, which becomes a plasma cell that manufactures antibodies. And a lot of antibodies are good antibodies, so they're kind of a reminder to the body of which infections you saw before. And then if you see that infection again, it will help you fight off the infection. But in some cases, the immune system becomes overactive and it produces this antibody that is not a normal antibody. And that is the aquaporin 4 antibody, which is also known as the NMO antibody. And this is an antibody which is directed against a water channel, which is part of a cell in the brain called the astrocyte. These astrocytes are normally supporter cells for the neurons in the brain, but they're not just supporters in that they're extremely essential for the brain's function. When the aquaporin 4 antibody binds to this water channel, it induces the death of the astrocyte and also destruction of the myelin. And that's why NMOSD is known as a demyelinating disease. The myelin is this insulating coating that runs along the axon. The axon is like the arm or long cable that joins neurons together. So when we lose myelin, the signals between the neurons cannot travel smoothly. So now we're going to talk a bit about having a first NMOSD attack in the Canadian system. So typical first symptoms of this disease do depend on which location is affected. One of the most common symptoms is vision loss or blurry vision. So that happens if the optic nerve is affected. Other common symptoms include weakness and sensory loss, and sometimes bladder and bowel impairment. Those can occur if the spinal cord is affected. And then some people present with their first attack of NMOSD with severe nausea, vomiting, and hiccups. This can be vomiting that happens, 7 or 8 times a day and doesn't respond to any of the typical medications for nausea. So when somebody develops one of these attacks, is often quite severe and usually it motivates the affected person to go to the emergency department. But occasionally the symptoms can be milder and they may seek out attention from their family doctor instead. So one challenge with the first NMOSD attack is because this is a rare disease, it has to be recognized, and the need for prompt medical attention has to be recognized as well by the doctor who sees the patient for the first time. So usually with a first attack, the person affected will be referred to a neurologist or an ophthalmologist, which is an eye doctor. But sometimes, as we know, living in Canada, referrals, can take a while to occur. And then the doctor who sees the patient has to think of the possibility of NMOSD and order the NMO antibody blood test. And an MRI is also often ordered to see what part of the nervous system is affected. So it's really important with this disease to be a strong advocate for yourself because there are often delays, but urgent and rapid medical care are essential to optimizing outcomes in NMOSD. So this was some research that we did in Canada. I lead a national study where we're looking at people with NMOSD. We're trying to describe the characteristics of different people living with this disease across Canada, and also what treatments they receive and which factors are predictive of how well they do in general, and also how well they do on specific treatments. So we looked at which symptoms were part of the first attack in Canadians who developed NMOSD. So the green here is optic neuritis. So you can see that about 32% presented with an optic neuritis attack with vision loss. Sometimes it was a bilateral attack in both eyes. Even more common was transverse myelitis, which is an attack on the spinal cord, and that can present with weakness, gait impairment, sensory loss, and bladder or bowel dysfunction. So that was the first attack in about 48%. And then we had 20% who presented with various brain attacks. Of those, 10% had what is still known, I should say, as the area postrema syndrome, which consists of the severe nausea, vomiting, and or hiccups. And then there were individuals who presented with other kinds of brain attacks as well. So How do we distinguish NMOSD from other diseases of the central nervous system? So this is an important concept for physicians, but I think it's also important for people living with this disease to understand how the diagnosis gets made. So the most important and most diagnostic test is the blood test for the antibody, as we mentioned. And that's because the NMO antibody test is highly specific. What that means is if you have a positive blood test, there's already 99% certainty that you have this disease because it is an abnormal antibody. So this blood test should never be positive, in somebody who has a normal neurologic condition. So that's a first step. There are other antibodies as well. So there's an antibody we can check in the blood called the MOG antibody. And people with the MOG antibody can have attacks that are also very similar to NMOSD. But if the MOG antibody tests positive, they have another condition called MOGAD or MOG antibody disease instead. So often both blood tests are sent at the same time to try to reach the diagnosis faster. Now, in the case of the multiple sclerosis, there is no blood test or antibody test, which is diagnostic of MS. So that diagnosis is made on the basis of the MRI findings, the physical examination, and also a typical clinical history. The clinical history is also important. So when we see a patient with NMOSD for the first time, we're asking, what kinds of neurologic symptoms did you experience? Have you ever had a history of previous episodes? And what was the recovery like? Because often with NMOSD, people have incomplete recovery from the attacks, whereas with the other diseases we mentioned, multiple sclerosis and MOG antibody disease, the recovery is usually relatively better. Another key test for diagnosis is the MRI. So on MRI, we look for the locations that are affected. And we already mentioned some of those key locations for NMOSD. And we also look at the length of the lesion. Because with NMOSD, we often see long lesions on the MRI, and that's in contrast to multiple sclerosis, where the lesions are a lot shorter. And you may be given a dye called gadolinium, and when lesions enhance or pick up the gadolinium dye, it means that they're relatively new and they're active centers of inflammation. We also often do spinal fluid testing, and this is done by a lumbar puncture or what some people call a spinal tap. So there's a specific test on the spinal fluid called oligoclonal banding, which is usually positive in multiple sclerosis, but negative in NMOSD. So if we see a positive test for oligoclonal banding when we suspect NMOSD, it's a bit of a surprise, and it might take us back to the drawing board and make us think more carefully about multiple sclerosis instead. And vice versa. If a patient is given a diagnosis of MS, but the oligoclonal banding test is negative, you may hear that they're going to test for, other antibodies like the NMO antibody. So I know, again, these images are a little bit busy, but these are images showing different lesions in the optic nerve. So the arrow signs in the different panels can show you where the abnormality is. But basically, the NMOSD panel is a middle panel here. So they're trying to show you that these lesions or bright spots in the optic nerves are longer in this condition in comparison to conditions like multiple sclerosis, where you can see the bright spots are relatively short. So this is just to highlight one of the imaging features that can help us distinguish between different conditions. So once you have a diagnosis of NMOSD, what comes next? Well, it's very important to recognize if a new attack is starting to occur, because the earlier we treat attacks in NMOSD, usually the better the recovery. And I use these words interchangeably. So attack and relapse, those are the same thing. But basically, an attack is defined by new neurologic symptoms that develop over hours to days, and they should persist for at least 24 hours. Sometimes underlying neurologic symptoms, though, can get worse for other reasons than it being a new attack. So if an individual develops a fever, has an infection, or has some other illness, like they're going into kidney failure, then they're not able to compensate as well as they normally would for their neurologic deficit, and their underlying deficits can get a lot worse and look like an attack. But we call that a pseudo attack because it's actually not caused by new inflammation in the spinal cord, brain, or optic nerve, but it's caused by the infection or the fever. And once that insult is treated, the neurologic symptoms should improve too. So when you call your neurologist, if you're having new symptoms, that's what the neurologist is thinking about. They're thinking about, could this be a new attack? And how am I going to distinguish between whether this could be a pseudo attack or a true new attack? It's very, very important, though, if you ever have any new symptoms with NMOSD, that you get in touch with your neurologist right away. And if your neurologist is not available, then you should go to the emergency department. There is evidence that if you treat a new NMOSD attack within the first few days, the outcome is much better than if you wait for a week or more. So how is this attack going to be evaluated? Well, your doctor is going to take a history and perform a neurologic examination. The doctor tries to formulate an idea of what part of the nervous system may be involved, and then they order investigations based on that. So they're going to order an MRI. If you're reporting blurry vision, we'll try to get an MRI where we have finer slices through the orbits and through the optic nerves. If you're complaining of weakness in both legs or the legs and the arms, then that would suggest a spinal cord localization. So we're going to do an MRI of the spinal cord. We might order some other tests to screen for a possible infection, as I mentioned. So blood tests, for example, or cultures for infections, like a urine culture, to help rule out that it is a pseudo attack. And then we might perform spinal fluid testing, although usually that is just with the first attack. And then often steroids are given as a first treatment. And the response to steroids can also be part of our evaluation of whether or not it's an attack and how severe the attack is. So how is an attack managed in NMOSD? Well, if the symptoms are severe, we'll admit the patient to hospital. We're going to perform investigations like the MRI. And then the first treatment is usually high-dose steroids by IV. But one key principle in management of an NMOSD attack is if the person is not getting much improvement with steroids, then we want to move very quickly to plasma exchange. Plasma exchange is more invasive and is only available at certain hospitals, and that's why we don't do plasma exchange right away. It's a little complicated, but as you can see from the figure here, the basic principle of plasma exchange is that blood is drawn out of the body and cycled through a machine to remove harmful antibodies, and then it's cycled back into the person. So there is good evidence that the degree of improvement is usually better with plasma exchange, but some people will improve with steroids alone. So we give the steroids first, but then we want to really quickly evaluate how well the person is responding, move on to plasma exchange if we need to. And we usually continue with oral steroids, which is called prednisone. And the prednisone is often used for several months because if steroids are withdrawn right away, then it's possible for the attack to worsen or the person can go into another attack. And then the allied healthcare team is also a really important part of recovery. So physiotherapy and occupational therapy are often involved. And the more a person affected works with therapists, usually the better they do with their recovery as well. And they may go to a rehab hospital once they're discharged from the acute care hospital. I just wanted to say a word about the new diagnostic criteria for NMOSD. These haven't yet been published, but they were announced at our recent international meeting, which happened in Barcelona at the end of September. And this is an international effort that's led by Dr. Wingerchuk, who's a renowned expert in NMOSD. And I had the privilege of being part of one of the committees that's contributing to the new criteria. I'll just talk briefly about some of the changes. One of the main changes is around how the disease is going to be named. So NMOSD is going to refer now to neuromyelitis optica spectrum disease instead of disorder. And it's going to be particular to people who test positive for the NMO antibody. So increasingly, we're recognizing that people who have this antibody in their blood have a distinct type of disease and they respond to specific treatments. We know there are other people who have symptoms and attack types that are similar to those with NMOSD, but they test negative for the antibody. And in the past, that's been known as seronegative NMOSD. But the naming of those diseases it's going to be expanded a little bit. So they're going to be called NMO spectrum syndromes. And then we're probably going to distinguish between people with those conditions based on which localizations have been affected. So if, for example, somebody has only had the spinal cord affected, then they may fall under this phenotypes category. Other individuals may have had attacks that affect both the optic nerve and the spinal cord. But ultimately, I think these new criteria are going to allow us to expand the umbrella we have for NMOSD, and that will be helpful in terms of getting people access to treatments. And it is also, I think, very useful to distinguish people who have the positive antibody because for those individuals, we have some treatments that have recently been proven in clinical trials to be highly effective, and hopefully it will expand access to those treatments here in Canada. So now I just want to talk a little bit about the long-term therapies for NMOSD. So we have some therapies that are used off-label. Basically, off-label therapies are defined by medications that have been used for years to treat a disease, but they were never proven using the scientific gold standard, which is a randomized clinical trial. So these include steroids, such as prednisone I mentioned. We also have azathioprine, mycophenolate, and rituximab. Out of these four, I would say azathioprine and mycophenolate are older drugs, and they're kind of what we call classic immunosuppressants. They have multiple targets. And our goal today with immune diseases is to have more targeted therapy. Because often when we suppress multiple parts of the immune system, we make patients more vulnerable to infection. And we may not be optimizing the target of the disease itself. So rituximab is another drug that's a monoclonal antibody, and it's infusion that's given every 6 months. I'd say this has become often the preferred approach for the first therapy in NMOSD in Canada. We used to have limited access, but once the drug became generic, access became wider in Canada. And it directly decreases the antibodies that we know are involved in NMOSD, but it doesn't suppress all parts of the immune system, and that can be helpful. We also have 4 other drugs that have recently been shown in clinical trials to be effective against NMOSD. So these drugs have all been approved in Canada at this point, but access does depend on which province you live in. And some of these drugs are very expensive. So some of them are not covered by the public system. Some of them are covered, but only with quite restrictive criteria, like if you have a new attack within the last year. But basically, 3 of the 4 are infusions, so they're given by IV into the arm, but the frequency of the infusions varies. So we have eculizumab, which is an infusion that's given every 2 weeks, inebilizumab, which is given every 6 months, ravulizumab, which is given every 8 weeks, and then we have one which is an injection that's given once a month called satralizumab. In the clinical trials, these drugs were all very highly effective at reducing relapses in NMOSD. So the reduction in attacks varied from around 70% up to 95%. So overall, those rates are better than the older medications, but I can't tell you that one of these drugs is better than the others because they weren't studied head to head. So it's very important to go on long-term therapy with NMOSD. So the long-term immune therapy is essential to prevent attacks, And we know that any attack in NMOSD can cause major permanent disability. And I often get asked, by patients, I've been free of attacks for 20 years. I feel great, but I have some side effects. I get a little nausea through my medication. It's a pain to take a medication all the time. I want to come off of my medication. What do you think? And I can see the logic of that, but unfortunately, because NMOSD is a lifelong disease, there's never a time where it's good to come off of medication and where we can reassure people that it will be safe to do so. And I have seen patients who have been attack-free with NMOSD for 15 years, 20 years, and came off of therapy because they were just sick of taking a medication. I mean, that's completely understandable, but unfortunately, they had an attack. So right now, we don't have any blood test or any test which is perfect at predicting that somebody will be attack free, and we have to advise people to stay on medication even into old age. So keep in mind, if you're having major side effects on your medication and you're not there tolerating the therapy well, we're lucky today that we have more options to treat NMOSD than ever before. So you shouldn't have to live with very bad side effects. You should talk to your neurologist about the other options that are out there, and a switch may be possible. When it comes to choosing a long-term therapy, there are many aspects to discuss with your neurologist or other healthcare provider. So all of these factors enter into the decision. So one important one is pregnancy or family planning. So a lot of the people diagnosed with NMOSD are young women. And they may be, thinking of having children in the future. There are some medications that are safer for pregnancy than others. So you definitely need to report to your neurologist if you're thinking of having children. Comorbidities can also be an important factor. We know many people with NMOSD are living with other autoimmune diseases. So if an individual patient has another, autoimmune diagnosis, we'll try to pick a medication that could potentially cover both. We also look at the severity of past attacks. So we want to pick, one of the strongest drugs in individuals where they've had really severe past attacks or poor recovery. And then we want to ask people about what their tolerance is for risk. So all of these medications are associated with some increased risk of infection, but some of them are associated with more serious infections than others. And then we want to get a sense of what, dosing frequency you can tolerate. Do you have a preference for a pill, an injection, or an infusion? And realistically, because some of these drugs are very expensive, cost and coverage does enter into the equation as well. So we have to see if a patient has a private drug plan. If not, we can apply for coverage usually through the government, but there are often more restrictions around which drugs we can access through the government. So just a word about switching therapies in NMOSD. When is the opportunity to switch? So when a person has a new attack, but also if you have problems tolerating your therapy, or if you have a significant adverse event on a specific medication. And how would you do this? Well, you would want to speak to your neurologist. It's not on you to investigate coverage options, but you need to give a little more information to your healthcare team about what kind of insurance you have, and then they should be able to help you look into which medications would be covered. And it is very important that your previous therapy may need to be overlapped with the new therapy, or if you've had a recent attack, you may need to take prednisone for a few months after the attack and while you're starting the new therapy, because it does take a few months for most of these drugs to come into full effect, and we want to prevent any new attack during the transition between medications. So I thought this was really interesting. You may have seen this story in the Globe and Mail over the last weekend. It was published on November 1st. Of course, there were many other important things happening at the same time between Halloween and the World Series. But this story highlighted how difficult it is for people with rare but severe diseases to access new drugs in Canada. So it's a very long process for new drug approval that often takes, as you can see here, out to 3 years or even more. And there are various stages to obtaining drug approval. So first, the evidence for the new drug is usually reviewed by Canada's Drug Agency. They give a recommendation. Then it flows to the Pan-Canadian Pharmaceutical Alliance, and they help with negotiation of prices based on the evidence. But then the individual provinces also negotiate with the drug makers in terms of their rules for funding and the prices. So the drug landscape for NMOSD is very complicated in Canada right now, and it's still changing. So, we're hoping we're going to have more access in the future to different options. And also, we can make requests on a case-by-case basis, depending on individual circumstances. So I just wanted to say a brief word about symptom management. So, we have interdisciplinary healthcare teams with many specialists. A lot of people living with NMOSD have chronic symptoms, which include pain, fatigue, vision issues, bladder dysfunction, challenges with walking, mood changes, and social isolation. So you can get referred to different specialists who can help with management of these symptoms. And the allied healthcare team, including nursing, social worker, PT and OT are also often very important in helping people manage and live with their symptoms. We also have many resources that you can access. So the MS Canada does represent people living with NMOSD as well as with multiple sclerosis. The Sumaira Foundation, which was kind enough to host this webinar, has various guides for patients posted on their website. There is also the Guthrie Jackson Foundation and the Siegel Rare Neuroimmune Association, and various podcasts you can access as well. So I think that brings me, just a few words in conclusion, and then we're going to have time for question and answers. So we talked about how NMOSD is an autoimmune disease of the nervous system. I wanted to leave you with a few key messages. Although we know NMOSD attacks can be disabling, we do have more powerful therapies today, and our goal is to completely prevent future attacks with long-term therapy. I want to remind you, if you develop any new symptoms, you should seek out urgent medical attention right away. New attacks do need rapid intervention with steroids and sometimes with plasma exchange. And your neurologist and also allied healthcare team are here to help you navigate the Canadian treatment landscape. So thanks so much for your attention, and happy to answer any questions.
Thank you so much for this very comprehensive presentation. So yeah, you guys can start entering your questions either into the chat or the Q&A function, and I'll get started with the first question. Okay, if 6 monthly rituximab infusions are improving aquaporin 4 positive NMO, how long can they be continued? Is there a limit of 2 or 3 years, or can they be continued lifelong?
Yeah, so an excellent question. As I said in my talk, people with NMOSD do need lifelong therapy. For rituximab, it can certainly be continued for many years. So, we have patients who have been treated with this drug for more than 10 years. We think it can be continued even out to 20 years or more. There are, I'd say some blood tests that we monitor often in people who are on rituximab. So we look at the cell counts. We also look at some of the antibody levels. So there can be sometimes an issue that the antibody levels slowly decline over time in people on rituximab. So when you ask about how long it can be continued for, that can be a limiting factor, but we do have strategies for dealing with that. So one of the strategies is to reduce the dose over time, which we can do safely in most patients. Sometimes we can space out the infusions. And in some places, if we see the antibody levels declining, we can give something called IVIG to replace the antibodies. That is more easily accessed, though, I have to say, in the United States than in Canada, because in Canada, it's quite expensive and they only approve it in certain cases. So it does depend on your individual case, and it would depend on how much the antibody levels have fallen. But I would say, in most people, we can continue rituximab for many years safely.
All right. While we wait for additional questions, I have a couple of questions. What percentage of patients living with NMOSD have other autoimmune diseases? And are there some autoimmune diseases that are more common coupled with NMOSD, like Sjogren's or lupus, than others? Like, what do you see in Canada?
Yeah, so in our data, we found that about 20% of people living with NMOSD have other autoimmune diseases. So that's a pretty high proportion. And there are certain autoimmune diseases that seem to be more common than others. So lupus, which you mentioned, was most often represented in our Canadian data. And then we did see other autoimmune diseases too. So Sjogren's, like you mentioned, Sumaira. There's another one called myasthenia gravis, which is actually another neurologic autoimmune disease. So in those situations, we try to pick a long-term therapy that can cover both diseases. And we usually work closely with the rheumatologist or the other specialist who is providing care for the other autoimmune disease.
Okay, very cool. Another question that I have a soft spot for, folks with from underserved communities, obviously, and from rural communities. And Canada, it's so big, but what I've heard is that most of the population is like takes up like a sliver of the country. So for the folks who are living above that sliver, how are they receiving care? How are they getting diagnosed? I'm assuming that the diagnostics are not widely available the further north you go. So what is the Canadian government sort of doing to help those communities?
Yeah, that's a really good point. Access does vary pretty broadly across Canada, and geography is one of the main factors.
Mhm.
Um, we are fortunate that, especially with rare conditions, the government recognizes the importance of seeing a specialist. So I have many patients in my practice who come from Northern Ontario communities, and actually the government will reimburse their air travel as well for them to come to Toronto to be seen in the specialized clinic. Um, so one thing I want to emphasize is that because NMOSD is a rare condition and the treatment is very specialized, you should be seen at, I would say, a clinic at an academic center, so a specialized MS clinic. So MS specialists also typically have expertise in NMOSD, but you wouldn't want to follow long term with like a general neurologist in the community because they often haven't seen enough patients living with this disease and they might not be aware of the latest treatments. Um, so it's really important, you ask about those government programs so you can get coverage if you need in order to travel to one of the specialized centers.
Okay, great. Next question in the chat. I love this question. How often should follow-up MRIs be done while you are on effective treatment and not having any attacks? So relapse-free, everything is stable. Should folks be getting periodic MRIs, I guess, preemptively?
Yeah, that's a really awesome question. And I have to confess, it's one neurologists struggle with as well. But the current guidelines are that you do not need MRIs with NMOSD in between attacks as long as your symptoms are stable. So this is really different from multiple sclerosis. So in multiple sclerosis, we do MRIs regularly for monitoring. But in NMOSD, it seems that like if you're going to have an attack, you're going to have a new lesion. And if you're not having new symptoms or an attack, your MRIs, generally speaking, are stable. And if there's a tiny change, sorry, it's not usually a clinically important one. So the guidelines right now is that there is no need for monitoring MRIs. In some cases, your neurologist might choose to have you do an MRI every few years. Um, in some ways, that's sort of a preemptive measure, but they also might want to check after an attack what your new baseline is like. So then, if you have any change in the future, they know what's new and what's old.
Okay. I have a question while other folks are coming up with questions. Um, so MS does not have a biomarker, but NMOSD and MOGAD do. And oftentimes, I forget what the current statistic is, but still so many of NMOSD and MOGAD patients are misdiagnosed with MS. So why don't we just test all MS patients for both of these disorders to rule it out?
Yeah, that is an excellent question too. It's a little bit of a tough one to answer, but in especially in a socialized healthcare system, we don't usually do tests unless there's what we call a high pretest probability.
Mm,
So, MS is way more common than NMOSD. So if we were to send the blood test for NMOSD in every patient, who we thought actually had MS, we would be doing a lot of wasted tests, number one. Number two, when you do a test often enough, it does return some false positives.
mhm,
So even a test like NMO, where having the antibody is always abnormal, we think 0.5% of the time, like 1 in 200, you might get a false positive result. So if you're doing that test often enough, you're going to end up with some false positives. And of course, you don't want to give somebody this diagnosis where they're going to be committed to medication for the rest of their life unless you have a lot of confidence in the diagnosis. And when you do the test for the MOG antibody, that risk is even higher than with
mhm.
NMOSD. So we get actually quite a few more false positives with the MOG antibody test. So we're actually pretty lucky with NMOSD that we have a very accurate test.
Speaking of diagnostics, so in the US, we have like a few centers around the country that are doing the live CBA testing, and it'll take sometimes weeks to get your test results. So in Canada, where are the different test centers? Like, are they abundant? Does it also take weeks to get back? Do you have to send it to a certain center? What's that landscape like?
Yeah, so the antibody testing is done at I'd say a number of different centers across the country, but again, they're often located in kind of major locations of academic medicine. It can be done though through places like Life Labs, like private community labs, and then they will send the test out to one of the academic centers where the test is actually performed. Usually we use something called the fixed cell-based assay. It's not perfect, but it does, at least for NMO, it has a very high accuracy rate. For the MOG antibody, the rate is a little less, but for NMO, it's actually very good. So in each province, I believe, almost all of the provinces, though, do have a lab where the antibody is done, maybe with a few exceptions. Yeah.
Okay. And so we're very lucky in the NMOSD community to now have approved therapies. When I got sick 11 years ago, we had nothing approved. It was kind of like no man's land. And you either went on rituximab or Imuran or methotrexate and, just tried whatever. So this is really good news for the NMOSD community that we have therapies that are designed for us and the data is positive for patients who have aquaporin 4 positive. So, what is advice that you can give to patients and I guess fellow doctors on how to transition patients who have been on rituximab for a while and want to get on one of these newer therapies?
Yeah, so it's a little bit complicated here in Canada because even with private insurance, to get approval for transitioning to one of the therapies, we usually have to show there's kind of a medical reason for the change. So there are
Oh,
two main categories. There are people who have new attacks, and then there are also people who have tolerability issues with their old medication, where sometimes we can justify the change.
mm,
So those are the situations where we can switch people over. What I would say though is if you're, someone who's treated with azathioprine or mycophenolate, it is easier to transition to rituximab, which has higher efficacy rates. So in a lot of, sorry about the background noise, in a lot
mm,
of situations, the rituximab will get approved because it's less expensive. There's a generic version that's available.
got it. Mm. Okay, there's another question. There is a blood test measuring levels of the GPR37 protein, which may serve as a promising biomarker. Is this test currently being done in Canada?
Yeah, no, it's not being done to my knowledge.
Okay. Okay. Um, oh, I forgot to tell the audience that you were just awarded with a very big award for your Canoptics registry for NMOSD. Do you want to maybe share a little bit about the registry and how patients might be able to help you?
For sure. Yeah, thank you. So we have a multi-center registry site in Canada that was launched pretty recently, just in 2021, but it's grown really rapidly thanks to the support of MS Canada, and we also have some industry sponsors. And then recently, we were really fortunate to secure some funding from Canada's drug agency. So the Canadian government has allocated funding to help develop registries in the rare disease space. And we're really excited that they've recognized, the importance of neuroimmune conditions and specifically NMOSD. So we have, let's see, we have involvement across 5 different provinces, and we have 9 participating sites. We're going to be expanding to at least 12 sites over the next year. And anybody is actually eligible to participate if they have an atypical demyelinating condition. So whether or not you have antibody positive NMOSD or you have seronegative antibody disease or MOG antibody disease, you're eligible to participate if your neurologic care is at one of the participating centers. And then we collect information about, what your clinical characteristics are, what medication you're on. We have some optional sub-studies, so we're really interested in the patient's experience, and we have patient questionnaires that get emailed out once a year. So if people are willing to participate in that, they're welcome to. And then we're also looking at biomarkers as well. So we're starting to expand into blood sample collection so we can look at interesting biomarkers moving forward. So we really hope that it will give information that's specific to people living with NMOSD in Canada, and that will also help inform treatment choices and approaches to management in the future.
Great. I have a couple more questions. So, since the symptoms of NMOSD can be so vague, chronic pain, nausea, etc., are there any frontline education efforts to educate clinicians about looking for NMOSD?
Yeah, I think that's, it's a really important question and project. So I'm pretty dedicated to this space. So I try to regularly give talks to other neurologists, and we meet with other specialists who may see patients presenting with NMOSD for the first time. So, for example, if a person has a bad attack of optic neuritis as their first attack, they may just get referred to an ophthalmologist. So we try to reach out to other specialists who may be seeing people with NMOSD for the first time. Yeah, the education is such an essential part of this because really, the physician has to think about the possibility of NMOSD and send that blood test.
All right. I've been on Imuran since 2004 and tolerate it well and have been mainly attack-free since 2012. In a recent brain MRI, I have 3 new brain lesions showing but remain asymptomatic. Would it be recommended to switch medications even without any new symptoms? Enspring was recommended but not available through funding. Rituximab is a possible option but not confirmed that it will be covered. So they have 3 new brain lesions, no symptoms. Should they be switching their therapy?
Yeah, this is a tough question. So as we said at the outset,
Yeah.
we're going to try to avoid weighing in on individual scenarios. And part of the reason for that is it's really hard without complete
Yeah.
information because, I would want to know what your neurologic exam looked like, if there are any changes on your neurologic exam, and, how your symptoms are fluctuating. Those issues might all inform the decision. So, one thing I can say that is not specific to this individual situation is sometimes we see what are called non-specific new lesions on MRI. So, sometimes we can see just, some small white matter spots in the brain. And we don't know for sure if they're caused by NMOSD or if they're just caused by aging or other vascular risk factors like having high blood pressure. But I don't know if that was the issue in your individual case because it would depend on where the new lesions were located. So again, it's just, I wouldn't want to give false advice or misguided advice without seeing the MRI for myself.
Fair enough. Do you advise patients masking up in public settings to curb infections, especially during the cold and flu season?
That's another tough one in a way. You know what? I think one of the challenges of living with a condition like NMOSD is social isolation. And that really came to the fore during the COVID pandemic, where, of course, many people were worried about going out in large crowds, but especially people who were immune suppressed. And we knew, that if at the height of the pandemic, if you contracted COVID, it's possible you could have severe respiratory consequences. So I think one important thing is to get vaccinated against the flu, for example. It is true that being on an immune suppressive medication, you may not get as much response to a vaccine as somebody who isn't on those medications, but you will get some response. You'll get some protection, and some protection is better than nothing. So the first step in protection, I think, is vaccination. And then I think common sense is important. So masks can reduce the risk, but what also reduces the risk is just, like avoiding kissing people who aren't close acquaintances. Make sure you're washing your hands with soap and water after interacting with people in a crowd. So I don't think there's a single approach or single step that's going to protect you from the flu or from infections. I think it's important to reflect on what's most comfortable for you. So some people find masks are very reassuring and comforting, and they want to get out and, interact with other people, but they will feel better if they have the mask on. But for other people, other steps work. And I think with having vaccines and taking some simple steps, you're safe to socialize.
Okay, final question. Approximately how many people are diagnosed in Canada with NMOSD? How can we register to participate in your study?
Yeah, so we've been trying to get a better sense of the numbers because there actually isn't a good published source for the number of people in Canada affected by NMOSD. So we're trying as part of this study to access provincial blood labs and also health claims data records to get a better idea of what the exact numbers are. So we just recently we were able to do that in Ontario, and we found about 180 people who are affected in Ontario, which turns out to be a rate of about 1 in 100,000. So it looks like our rates are quite similar to what's reported globally. But we are going to try to get numbers that are specific to each province because the prevalence may vary by province. And I think we do need our own Canadian numbers, which will help inform resource allocation moving forward. So that's just a word about the numbers. And now I think you asked as well about participating in research. So you can feel free, to email me or my team, and we can tell you if the center that you have your care at is a participating center in the study. So unfortunately, we can't offer participation to people who aren't seen at one of the participating centers. It's just because of research ethics rules, because we have to make sure that the study, is officially approved by that hospital's research board. But there are some types of research that are done by surveys online, so we may look at that as another means to reach people with NMOSD in Canada in the future. For now, if you're interested, yeah, just shoot us an email and we can tell you if your center is a participating center.
Perfect. On that note, thank you everyone for joining live for the great questions. Thank you, Dr. Rotstein, for your time, knowledge, and expertise. We are so looking forward to seeing everyone in person on Saturday. And once again, this is going to be available on our website and on YouTube. So if you missed it or had to leave early, it will always be there for you. Thank you, Dr. Rotstein.
Thanks, Sumara, and please join us on Saturday in person. We're looking forward to seeing you.
Bye, everyone. Good night.